Thank you, Jennifer. Good morning, everyone. How are you? So I love coming back to New York, and I actually was an undergrad here, so it's always a bit of an emotional trip to come back to Yale. But it's especially nice to come back to speak about something like social entrepreneurship, because to be honest, had no idea what that was until about 4 years ago, at least as a concept, or to be called a social entrepreneur, until around the time that I started Seed Global Health. And then suddenly I developed this label of social entrepreneur, and it was it's been a fascinating journey to own that label, to do justice to what that can mean, do justice to the predecessors who have borne that title, and continue to try to do so every day with our organization. If you think about it, in many ways, there's a lot of very prominent people and organizations who would have say they started as social entrepreneurs in terms of developing an idea, building it out for a social good, and then bringing people into their movement. Partners in Health, led by Paul Farmer. In many ways, I think that is your prototypical example of developing something around an idea that is for social good. You could argue that MSF very much started in the same vein. And so I think that the power of social entrepreneurship to change the world is very profound, and it can be done both small and locally, but it can also develop into something very big. What I want to talk about today is our attempt with something very small to begin to change a paradigm around health systems, and to explore how we've done that a little bit, and to explain the problem that we're trying to solve. So we're going to talk a little bit about some of the challenges in health that exist and what those challenges have created for us. The role of people in solving some of those challenges, specifically looking at human resources for health and the gap that exists there, and then sort of what the solution might be, or the solution that we've proposed to help solve that problem. So there's a problem of global health, if you will. And one of the problems that I think exists in global health, and I talk about this in every talk, is that there's no standard definition of what global health is and what it means. So the approach to global health has effectively, it's evolved over time. It started with the idea of tropical health, which was a colonial-based idea that companies from Europe were going to Africa or India or elsewhere to do business, and their workers were dying from some problem or another. And as a result, they would send doctors and health workforce to care for their health care, their workforce, so their workforce wasn't dying, and that was sort of the tropical health. That then evolved into this idea of international health, which is there is a problem there that we don't have here, and we're going to go do good and try to fix that problem there, which was a bit of a paternalistic, medical touristic sort of approach to doing health. And then evolved this idea of global health, which was supposed to be a little bit more holistic, a little more embracing of all these different impacts into human health. And one of the best definitions of global health that I've ever seen actually was in The Lancet in 2009 by Jeffrey Copeland and some colleagues that defined global health by these parameters. And for the sake of time, I won't read all of them, but what you'll really highlight is that it's a scope of problems. It's not bound by geography. There's very complex interactions that go into the health of individuals. And you need to use, therefore, a whole diverse series of resources in order to solve those complex problems. And importantly, we need to accept that health spans a spectrum that is both from prevention to care to management, and that there's a whole range of people and a range of points of intersection that are very important. And I apologize, this was in Lancet in 2009. I forgot to put the reference up. But if you look at global health, there's some very real problems that we need to accept. And one is that there's a disproportionate burden of disease in various parts of the world. So the first would be HIV. 97% of the world's HIV is actually in one area of the world, and 75% of HIV is actually in sub-Saharan Africa alone. So there's a very disproportionate burden of disease around HIV, which has been one of the biggest global epidemics we have ever seen in our short time on Earth. You've non-communicable disease. 80% of non-communicable disease deaths are happening in lower middle income and low income countries. And in maternal mortality, a staggering 99% of maternal mortality is occurring in very few countries around the world. One particular demographic of low income countries around the world. There's quite a few countries that actually fit that demographic. And again, the vast majority is in sub-Saharan Africa. This is just another way to look at the maternal mortality map. I'm sure you've all seen the World Mapper. If you haven't, just type in World Mapper in Google and go and play with all the different maps they show. But it shows you visually sort of where the majority, it inflates countries that have the majority of whatever condition and deflates the countries that have less. And so this is the maternal mortality map. And it looks awfully similar to the infant mortality map, which looks inverse to where physicians are working in the world, where nurses are working in the world, and where public health spending is actually done. So this is all just to re-highlight that the bottom line is that there is inequity. There is intense inequity across a number of parameters in the world, around human resources that are available, around the infrastructure that is available in these countries, around the burden of disease that people are trying to tackle, the technical capacity to think and solve some of these problems, and then certainly access. Access to care, access to education, access to information, access to human rights. All of these things are creating a vast problem that needs to be solved. So what is the solution, and who is working on the solution? So there are global health actors that are worth exploring, because it's actually a very complex environment now of actors that are getting involved in this space. You have the state, which would be governments like the US government or the government of Ghana. You have market forces, which might be pharmaceutical companies, various business coalitions, chambers of commerces. You've got civil society, which might be NGOs that are and organizations and groups that are working. You've got the actual patient population themselves that are suffering from certain diseases. And then you have sort of areas of overlap. So you might have something like the Global Fund for AIDS, TB, and Malaria, which falls dead in the middle of this Venn diagram. It has participants of civil societies that are helping to determine on the ground where that money is being spent. You have a whole series of companies, corporations, international NGOs, and governments that are giving money to the Global Fund in order to fund that force and help make the policies. So, or you might have something like the Gates Foundation, which is in the bottom middle here, which is an example of civil society and market. You've got a single individual that raised a huge amount of money and now has decided to donate it to creating better health. But a lot of the money that that individual created came from market forces, and equally the Gates Foundation influences markets, or the Clinton Health Access Initiative might influence markets, because even though they're a private NGO or foundation, they have the ability, with the billions or millions of dollars that they use, to create pooled markets, to drive pricing. So the Clinton Health Access Initiative, for example, basically drove the price of HIV medications down to $140 because they said, we're going to bargain on behalf of X number of countries that need these drugs. We're going to create that pooled market for you. And because we're going to bring you this much of a market, you need to bring your price down. And it was incredibly effective. There's some key stakeholders that we know about that we have to think about, like multinational and international organizations, all the UN-based organizations. You have things like the Global Fund, you have Rollback Malaria effort, you've got countries and individual countries, you have the private sector, you've got universities and academic influences that are driving, doing research, or that are building partnerships, or that are becoming consultants to governments. You have, so for example, the Harvard School of Public Health is consulting the government of South Africa and building out its health administration, has created a course to help do that. You have civil society and you have individuals. I want to focus, though, on one particular actor that we need to be very careful that I think we keep first and foremost, which is the healthcare worker working in the countries that share the largest global burden of disease and that are facing very poor resources to support them, but are at the forefront of this battle to improve health in these places. And what is an issue is that this health workforce is not distributed evenly around the world. So the World Health Organization says that there is a critical shortage of about 12.9 million doctors, nurses, and midwives by the year 2035, and that currently today there are 7.2 million in a shortage of doctors, nurses, and midwives. And if you look at the distribution of these shortages, they are found much more profoundly in 83 countries around the world. This map actually reflects data from about a decade ago, when it was only 57 countries that were estimated to have critical shortages. That number's now been revised to 83. But you can see there's a pretty tight geographic distribution of where these critical shortages exist. Why that has happened, in part, is because of a phenomenon of brain drain and emigration. So a colleague of ours at Seed Global Health did a study in 2005 that looked at basically the patterns of migration of healthcare workers from parts of the world, and found that most healthcare workers were emigrating to 4 countries, which was the US, Canada, the UK, and Australia. But where were they coming from? Looking at the top 20 countries that had the highest rates of emigration of healthcare workers out of the country, the first was the Philippines. Part of that is because the Philippines actually trains people to leave, with the idea that if they leave and they make more money elsewhere, they can bring remittances back to the country to help support the country. That's sort of an active plan of the Philippines. The next 2 were India and Pakistan. But of the top 20, 9 of the top 20 countries with the highest rates of emigration were based in sub-Saharan Africa. And that looks a lot like that geographic map that we looked at that had the critical shortages. And so these countries are losing a lot of their healthcare workforce to go to other places. This phenomenon of brain drain is driven for any number of reasons. Part of it might be you can make more money elsewhere. But one of the top reasons that's been studied as to why people leave their country is because they can't practice what they trained in. They don't have the resources, or they don't have the professional development opportunities to actually, be the kind of professional that they hope to be and they trained in. And what that has led to, that phenomenon, has been a healthcare leadership gap. Over the last 15 years, with PEPFAR coming on and putting all this money into global health and changing this idea that we could treat people with HIV, and that we needed to increase health access. There's been a huge influx of frontline healthcare providers, community health workers, and sort of adjunct healthcare workforce that is great at improving access. But what has not happened is that there's not been the same focus on the healthcare leadership. These are skilled health professionals that can not only provide excellent care, provide the backstop to these frontline healthcare workers when somebody has a ruptured uterus, when somebody's hemorrhaging, when malaria becomes cerebral malaria, or pneumonia requires a little bit more intensive care, to be the backstop for those frontline healthcare workers, but also importantly to keep teaching. Turns out there's a major faculty shortage in many of these countries to be able to train the healthcare workforce, which means the healthcare workforce is reliant on external trainers to come in and train them, and that there's no sustainable pipeline for future healthcare workforce. And what this looks like, a colleague of mine typed the word HIV into PubMed and looked at the first 300 articles that popped up when you typed in HIV, and looked at the first author of each of these articles and mapped their home institution of the first author. And what you see on here on this is a map in red of the global burden of HIV, and so darker red means more HIV, and as we talked about before, most of HIV is in sub-Saharan Africa. But when you type the word HIV into PubMed, this database for research and articles and literature on HIV, and you map the first author, the person who technically probably drove the research question and wrote the article, 37% of those first authors came from North America, 21% came from Europe, and only 8% came from sub-Saharan Africa, where HIV is the biggest, and where the health workforce knows very directly what it means for their neighbors and their communities to be affected by this disease. So this is the gap that we're trying to close at Seed Global Health. To talk a little bit about the healthcare workforce, in 2006, the World Health Organization issued a report that came up with a not particularly, surprising finding, which is that the more healthcare workers you have, which is on your x-axis, the higher survival you have of a population, which is your y-axis. And it seems like a shocking revelation, right? But the truth was, it took seeing this on this kind of graph for people to say, my God, we need more of a healthcare workforce. And this began the movement of talking about how we train the healthcare workforce that we need. I talked a lot about how there's been a big effort on increasing the frontline healthcare workforce, but what we have tried to do is to focus on that leadership gap that we outlined. So we started Seed Global Health as a nonprofit back in 2011 actually, with the idea that we were going to focus on this idea of the health professional, to train the next generation of doctors, nurses, and midwives in these countries so that we could build a pipeline of future doctors, nurses, and midwives who would be able to provide outstanding care, be the backstop to these frontline healthcare workers, but importantly, be able to train their successors and be able to build the strategy in these countries for solving these healthcare workforce problems. So to give an example, if you train an OBGYN, one OBGYN can train a skilled birth attendant who can address, basic labor in the village, a midwife who might be able to deal with some more complex birth problems, or another OBGYN who can deal with preterm birth, ruptured uterus, fistula, and other things like that. We decided to design our program in partnership with the U.S. Peace Corps, with the idea that the U.S. was already putting a lot of effort into health and to health education, but maybe wasn't doing it in the most complete way yet. And that we could take advantage of the Peace Corps' 50-year history of sending Americans abroad in a culturally sensitive and integrated way. They have the administrative structure to put 6,000 to 8,000 Americans in countries around the world already. And we didn't have to invent that. We could focus on things like the medical and technical and nursing expertise needed to recruit, place, and train volunteers to work for a year of their lives and to support them in the field while they were there. But we did feel that building on the idea of the Peace Corps was important, because back in 1960, when then candidate Kennedy gave a speech on the steps of the University of Michigan, he asked specifically how many of you are willing to be doctors, how many of you who are going to be doctors are willing to spend your days in Ghana. And it was that idea that you could bring increased technical experience through the Peace Corps volunteer to these countries. But the Peace Corps didn't know how to do it alone. So we created a public-private partnership to do so. We also built on the fact that this was back at a time, this was a PEPFAR sort of decision back in 2009, that they needed to do more focus on training. And what it says here, I realize the font is small, is that PEPFAR really emphasizes the idea that health system strengthening goals for prevention, care, and treatment is critically important. And that if all healthcare workers are going to be critically important to the overall HIV/AIDS strategy. And that training and retention of healthcare workers, managers, administrators, health economists, civil service employees would all be critical to the function of a health system and critical to PEPFAR. And most importantly, that one of the targets for 2010 to 2014 was going to be supporting and training and retention of 140,000 healthcare workers. So with that sort of set as the stage, we were able to say, hey, fund this program, PEPFAR, because we're critical to your overall strategy. We ended up launching this public-private partnership with the Peace Corps in 2013, and this is a picture at the White House of the formal launch when we sent out 30 doctors, nurses, and midwives to 3 countries in Africa. The model was that these folks would serve as clinical faculty for at least 1 year. It was very important that they stayed for a year, and we'll talk about why in a moment. Very much in partnership with host country institutions, these individuals embed as faculty in these local institutions. They live like their colleagues. They are integrated into the fabric and society of their community, and they are there to help really build on the existing clinical training systems to meet the prior training priorities of the institutions where they work. The volunteers, very importantly, need to be fully trained. So this was important because the African medical system is hierarchical. And a lot of folks think, oh, we can send a 4th-year medical student and they're better than anything that is there. I got news for you. A Ugandan medical student will be able to tell you the pathways of low sodium in your blood better than any American medical student. Where the translation has happened, or the sort of loss of fidelity has happened, is in translating things to the actual bedside. Because the Ministry of Health will pay for teachers to teach. The Ministry of Health will pay for doctors or nurses to work in a hospital. And the Ministry of Education will pay for you to teach in a medical school or a nursing school. But nobody is teaching you or paying you to teach, I'm exhausted, paying you to teach at the bedside. And what that means is that there's no bedside or clinical mentorship that's been happening for these students and these trainees in the hospital. This is one of the biggest areas of impact we can make. It's called the no-do gap. You may know something, but you don't actually know how to do it. And so this is a place that this model has had a tremendous impact. And what we do differently than many other programs in the world is that we build on this idea that one doctor or one nurse can train 10 more, and that those 10 will then go on to train others, and so on. So you get this force multiplying effect that will go on forward. The way the model works, and we actually execute it, is that we've partnered in 3 countries, and it's sort of basically a dorky version of online dating. We partnered with ministries of health and ministries of education in these countries, and we asked them, what sites do you want us to go to that are priorities for you in your country? The first question we asked is, do you want this program at all? When the answer is yes, then we asked, what sites do you want us to go to? And we invited sites to apply to the program to make sure they had the right kind of student, they had the right vision and the right sort of match for what we were trying to do. And then we asked them for what their training needs were. And based on that, we started recruiting American doctors, nurses, and midwives who fit that profile and place them to work at the institutions to try to meet the institution's needs. Institutions review the CVs of the volunteers that we offer to send them to make sure that they're comfortable in agreement that this is a good fit. And what this looks like in practice is that we sent 30 physician and nursing volunteers in July of 2013 to 3 countries. These are 3 countries, and if you look on the bottom of this area here, these are the statistics of the number of doctors and number of nurses for every 100,000 people in these countries. Just for perspective, it is about 980 nurses and 240 doctors for the same population in the United States. So that should give some sense of the disparities that we're dealing with in these countries. In 2014, we sent 42 volunteers, and this year we have 33 volunteers working in these 3 countries. We are now slated to expand to Swaziland, which has the highest HIV rate in the world. It is a small country of about 1 million, landlocked essentially by South Africa, sharing a small border with Mozambique. And it has the highest HIV rate in the world. And what's amazing about Swaziland is this entirely nurse-led system. So this will be a really incredible place for us to work as we scale up nursing education and training. And then we're also going to go to West Africa, to Sierra Leone or to Liberia, with the idea that fragile health systems are why Ebola was allowed to erupt the way it erupted, and we want to help rebuild and change that paradigm, because Ebola is going to be endemic in that area, and we don't want to see that kind of epidemic happen again. Our partner institutions, we worked with 11 partner institutions in our first year. In our second year, we added 2 more in Tanzania to go to 13. And then this year, we actually went to 2 new ones in Uganda, and we left 2 sites in Tanzania. And the decision to leave was not an easy one. But one of the things that our country representative in Tanzania, so we have part of our team is a local Tanzanian clinician who runs our activities and oversees sort of the work that we're doing in Tanzania. And when we interviewed him, he said, I hope you're only working with sites and places that want to have some skin in the game and are making an investment with you, because we feel, he said, if you're not, you need to think about being at a different site. And it's very difficult to think about doing that, but it's true. We realized we needed to really work with partners that were going to take advantage of the resources that we were giving them or partnering with them for through the year. And so we ended up very difficultly leaving one site that wasn't willing to provide housing for a volunteer, and we left another site that wasn't really integrating the volunteers into their faculty, into their day-to-day program. We haven't left them entirely. We are going to be visiting them again this year to see if things have shifted and changed. We do feel committed to them, but we also wanted to know that we weren't putting resources in places where they weren't going to be used as optimally as they could be. The process that we do this is that we recruit, screen, and place volunteers. We do require sites to review and approve the volunteers that we're going to be sending them. We want them to feel comfortable with who they are, what their background is. We have some sites that refuse to take just out of residency. They want older volunteers with more clinical experience. Sometimes we don't have a great match. The sites requested maybe a radiologist, and we didn't find a radiologist that we felt had the qualifications to be able to work there. So we would offer them something else, but we want them to feel comfortable with that, and they have the right to reject. The big thing we do is we bring all of our volunteers together for a 2-week orientation in Washington, D.C. before they start. The orientation is a bit of a fire hose experience in terms of drinking through a fire hose for tropical medicine and introductions to various disease management experiences that you might have while you're there. But the most important thing we do is that we talk to you about what it means to be a clinical educator in a resource-constrained setting, to teach and to provide care in that setting. We bring our volunteers back, we bring in our country reps, and we bring in program managers from the countries where we work to talk about what that means as well from a very personal voice. Because while we may not totally get you ready to know what that means until you're there and on the ground for a few months, we want your eyes wide open that you don't know what that experience is until you're in it. And that your job when you first go is to look, listen, and learn, to observe, to go to weddings, to go to funerals, to take your counterparts to tea, to become part of the community that you're in the best you can. Because that is the only way you're going to build trust and understand the true challenges that you're trying to embark to be a part of the solution on. And that has been, I think, one of the most important things that we have done. After the 2-week orientation in Washington, you spend 2 to 3 weeks doing orientation in your country, getting exposed to the health education system, the customs, the traditions, getting intensive language training, maybe doing a home visit to understand a little bit more about where you are and where you're working. And I think that one of the things that we've heard from a feedback perspective is that our volunteers have actually done a pretty good job of doing that. In fact, one story that I love is that we had a volunteer who is a white American from San Francisco who spent a year in southwestern Uganda, and there were some other visitors who had come to the site in southwestern Uganda, and they saw Ari under the bed working to fix a Foley catheter. And the visitor said, "Oh, who is the Mzungu?" which is the sort of slang or the term for a white person. "Who's the Mzungu under the bed?" And the Ugandan tour guide said, "Oh, that's not a Mzungu, that's Ari. And he's one of our volunteers here, he's one of our faculty." And that was maybe the greatest compliment I think anybody could have gotten, our program could have gotten. And it was just, it was a nice reinforcement that we are working hard to try to create that kind of integration. And I won't pretend we hit it right all the time. We have had some volunteers that have never quite gelled. But it is our job to hold that kind of partnership and that kind of integration as the gold standard that we are striving to achieve. We have sent a number of specialties in years 1, 2, and 3 in both medicine and nursing. One of the things we've learned is that the first couple of years we've maybe been a little too reactive. You wanted a urologist? Sure, we'll find you a urologist. What we figured out now is that we're going to be more intentional about the kinds of specialties that we recruit, so that we're going to work with the College of Medicine in Malawi to build out their family medicine residency, send them a set number of family medicine residents per year for the next 3 to 4 years, so that they will graduate their own family medicine residents who will then become their faculty. So we make these partnerships with the universities and the institutions that will help them train up a specific area if they will then actually hire that area going forward. The impact, we won't totally know, because the impact, it turns out, is going to be seen over time, right? How many of the people we train stay in country? How many of them continue teaching? How many of them in the public system have the health outcomes improved? That's impact. But we have some early outputs and anecdotes that tell us that we are moving in the right direction. In years 1 and 2, we have reported a fair number of work hours across our volunteers. We have taught over 300 courses, competencies, skills, and new teaching modalities. And most significantly, we've trained over 7,200 doctors, nurses, and midwives over our first 2 years. And our 3rd year is in the field now. This gives some idea of what the work hour distribution looks like for our volunteers. Nurses are on the left and physicians are on the right. The nurses spend much more time in the classroom and doing teaching preparation for didactic and classroom education, much less clinically on the wards. And that is very much, I think, unfortunately, just a vestige of where nursing education is now. And we are now trying to move the dial into increasing the nursing clinical mentorship on the wards, because that is a place of desperate need and I think an area for desperate change. The physicians spent much more time teaching in the clinical setting. And we really saw that impact with sort of what students, what trainees, and what co-faculty walked away from in terms of experience. And one example I will give, and I will end with some stories, is that doctors, and we had one doctor who was working in Tanzania, and she walked on the wards very early in her time and would either find babies dead or babies, gasping for air, desperate to breathe. And she realized that no one was very comfortable with neonatal resuscitation or neonatal sort of respiratory care. So she started to teach that very specifically to her trainees. And then her trainees quickly caught on that she'd see her trainees just recognize early respiratory distress and just go and take care of it on their own. The trainees then said, we really ought to hold a workshop for more people. And they ended up holding a workshop. 8 of her students helped her hold a workshop for 200 people to focus on respiratory distress in infants and children. And from that, now that workshop is going on the road around Tanzania, being held at other institutions to be able to have the same kind of impact. And I think that that kind of clinical shift is a very profound area of impact that our program has had. Our volunteers have also engaged in a number of projects as they have been doing their work. And so one program was that they started a Hep B vaccination program for healthcare workforce. So the healthcare workforce was less at risk when they had needle sticks and things like that they would be protected against that. They developed guidelines around neonatal ICU incubators, protocols around OB, labor and delivery. Somebody started a whole maternal education center. So all these projects grew out of recognizing the need on the ground, and then they worked closely with their counterparts and colleagues to build a solution that was really coming from the ground and the end user. Some of the key outcomes we've seen among students have been strengthening clinical supervision and teaching and promoting critical thinking, moving away from this idea of memorization and promoting critical thinking. Among the faculty has been introducing new teaching methods and supporting faculty to modeling professionalism, especially conversations between doctors and nurses. At institutions, we've expanded physician and nursing education opportunities. We've helped build resources, and we've helped develop curricula. We've seen the impact of that. One of our volunteers was told when he left that he reduced mortality on the wards in the year he's working in a way that they had never seen before, and that 5 graduating postgraduate residents who would have ordinarily fled for the capital had asked to stay on and continue working at this small rural institution in northern Uganda. So having an impact as well on retention. The overall impact that we are achieving and hope to continue to achieve has been strengthening the nursing and medical education overall, focusing on this idea of health system strengthening. So we're going to be now engaging the ministries of health and higher education and of finance about how do you make investments in your healthcare workforce in a way that you can keep and retain these folks, continue to build quality education, and strengthen the health system as a whole. We see this as a new face of diplomacy. These are Americans serving in a very new way, and our colleagues have told us that this has started to shift their idea of how Americans are in health and moving away from this paternalistic approach to much more of a partnership. Low cost, high yield. We can put an American in the field as a 1-year volunteer for about half the cost of other programs because we're building on the infrastructure of the Peace Corps and that economy of scale, and we're bringing and focusing on our own expertise. And then finally, we're looking to change across generations. And we're going to talk a little bit about what that looks like as we talk about some of the stories of our volunteers. So just to end, I want to talk about several of our volunteers and who they are and what they've done, because I think their stories exemplify what we're trying to do and what we've achieved. This is Maureen Reese. She's an OBGYN. She's our clinical director of OB now, and we hired her to stay on. She and her husband served in northern Tanzania at a remote rural area called Sengerema. And one of the things that happened to her is that within hours of arriving at her site, I mean literally within 6 hours of arriving at her site, she's unpacking and there's a knock at the door. And one of the nurses has come to get her and they said, "You have to come urgently. There's a pregnant woman in the operating room and she's dying." So Maureen sort of introduces herself and goes running off, and she walks into the operating room and she realizes it is way too late for her to save this woman, but she's going to try to save the baby. She performs her first ever postmortem C-section, and she ends up delivering what was undiagnosed twins, and she loses both babies. This is her first 6 hours at her site. Maureen is completely traumatized. But what Maureen didn't know, and what we didn't really know, is that 1 woman dies every hour from a complication of pregnancy or childbirth in Tanzania, especially in a remote and rural area. So Maureen wrote back to us and sort of reported that she'd had this experience. She said, "Tomorrow has to be better, right?" Well, it turns out the next day, the same similar thing happens, and she's called urgently to the operating room. And this time she goes, and there's a pregnant woman with a ruptured uterus who'd been in labor in the village for 3 days. She lost the baby, but she was not going to lose this mother, and she ends up performing the life-saving procedure on the woman that saves the woman's life. This is a woman who has 5 children at home, 5 children that she will now go back home to, and they're less likely to be socially and economically disadvantaged. But Maureen also taught all of her counterparts this same procedure and the indications for doing this procedure, and she repeated it over the course of the year so that now her counterparts that are working there know how to do the same procedure with the same skill and fidelity that Maureen did. And so that one woman who dies every hour from a complication of pregnancy and childbirth hopefully will not be now in northern Tanzania because of that impact. Maureen also held a workshop for labor and delivery nurses and taught them the latest protocols on labor and delivery. And about a week after she held this course, some of the doctors from the district ended up coming to her site and said, "When did you come to the site, our sites, and teach?" She said, "I didn't. Why?" And it turns out that all the nurses in these districts around the region where Maureen worked knew the latest labor and delivery protocol. And it's because the 45 nurses that Maureen had taught had all gone out and taught them themselves. So there's a horizontal impact across Maureen's work. Finally, Maureen demonstrated incredible creativity. She discovered that none of her students knew how to sew up a vaginal laceration, which is common in childbirth, which means that if you don't sew it adequately, people might go on and develop fistula, have other complications, infections. So she figured out, how can I teach my students to do this? And she figured out how to build models out of foam and coffee filters. She built vaginal models, and she held a workshop teaching all of her students how to do this. And it completely transformed this particular aspect of care, because then they could take this teaching into the village and increase people's knowledge of how to deal with this particular complication. This is Stephen Humphrey. Stephen and his counterpart, Pili Chilo, worked at the largest hospital in Tanzania, which is the Muhimbili National Referral Hospital. It gets over 1,000 new inpatient admissions a day. Stephen is a cardiologist, and he spent the year mentoring Pili, and together they changed how heart failure admissions were accepted onto the ward, which changed how people were educated around heart failure admissions, increased the efficiency, and increased the quality of care. Further, he helped guide Pili in bedside ultrasound and helped teach her how to be an effective ultrasonographist for teaching and for patient care and management. Pili now has actually been appointed to the head of internal medicine at MUHAS, and she is now leading the institution in a non-communicable disease effort that they're trying to work with the World Bank on. And through this work and care together, she has really become an international force, building partnerships and growing what her institution's resources and quality and education and training and delivery of care can be. Stephen also did innovations like holding Meet the Professor rounds. When many of the other professors would go to lunch, Stephen would show up on the wards and meet with his students and talk to them about cases and give them very direct mentorship. One of his mentees, John Mita, now is the only cardiologist in Dodoma, which is the capital of Tanzania. And he is working there now and teaching and training in cardiology. And that's exactly the kind of successive generation effect that we want to see. Finally, this is Kelly Lippi. Kelly is a nurse who worked in southwestern Uganda with her husband, who is Ari. Kelly had 160 nursing students when she started, and 158 were nurses because they had no other choice. They didn't get into nursing school, they didn't get into medical school, they didn't get into veterinary school, so they reluctantly became a nurse. 2 had chosen to be there. Kelly was determined to change that perspective, and she spent the year teaching these nurses what they could do in their profession, teaching them clinically on the wards, showing them how to be advocates for their patient, actually teaching them the various aspects of the exam, so that they ended up teaching the medical students neurological exams because they knew it better than anybody else. She showed them that even if your patient is going to die, they can die with dignity, because you can help them die pain-free, or you can help them be their advocate so that they can have a more dignified death. And when she did her evaluations at the end of the year, she asked all of her students, she asked all of them sort of, how has this course been? What has happened? And they all essentially wrote the same message, which is that Kelly showed them that they had chosen the best profession in the world. And more importantly, several of them went on to write they couldn't wait to teach their own future students this same sense of pride and the same experiences and lessons that they had learned. And that's the impact over successive generations that we're looking for. Our job is going to have to be to help monitor and evaluate this, to understand our impact over time and to tease all that out. And that's not an easy solution, and we can talk a little bit about some of those things. But what I do want to do is to sort of open this up to questions and conversation and dialogue with all of you now, and to hear your thoughts going forward about just your responses, your reactions, any of the challenges that you're facing. And I thank you very much for your time this morning. Any questions? Okay, I'm going to step down so I can see all better. Yes, right here in the front.
So first of all, thank you so much. This is amazing the work you guys are doing. One of the challenges you mentioned is that nursing and nurses and doctors and medical professionals leave because they don't have the opportunity to stay. So it seems like the impact in training people and getting them to stay, it looks like it's working. Are there more resources to then keep those medically trained people there and pay them a salary so that they don't leave?
So that's the ultimate question. I mean, I think one of the big things that we're struggling is that, as a small organization, we have a mission. Our job is to stay on that mission, to do our core programming well, because we don't want to deviate from that, or we're not going to be able to deliver on what we are delivering. But the lessons that we have learned is that we also can't work in isolation. That we need to think about the environment that we're working in and try to have an impact on that. And so one of the things that we have started to do is to ask ourselves, I've called it mission creep, but I don't mean that in a negative way. I mean that in maybe the mission should creep. Maybe we need to be a little bit more holistic in what we're doing and challenge ourselves to think differently. And so we have learned a lot about places that we need to have an impact. So one of the things that we have definitely learned is that we can't just be on the ground up. We need to come from the top down. So part of the reason we've now gone on to hire country representatives, which is one of our biggest investments, is we're hiring local folks familiar with the healthcare system, either doctors or nurses who have some kind of clinical background, who are experienced in the healthcare system of their country, in the health education system of their country, have worked with NGOs, who can be our voice on the ground and our advocate, and frankly help us navigate some of the cultural nuances, and to work with the ministries of health, the ministries of education, the ministries of finance to say, all right, we're coming in and we're training people. What is your commitment, though, to this population? Are you going to increase the salaries? Are you going to help sponsor people through training? Because here, when I was in residency, I complained because I earned not very much money as a resident, and I worked slave hours, and I was getting my butt kicked, but I got paid. In much of sub-Saharan Africa, you don't get paid for that same level of training. You are actually paying to do that training, and that is a major rate limiting step. So recognizing that bottleneck, we've actually decided we're going to sponsor scholarships. We're going to pay for people to train. So if we're bringing in faculty, we're going to ensure that there's trainees to work with our faculty that can come through the pipeline. But if we do it, we're actually now going to work with the ministries of health and the institutions to make sure that they're hired when we're done. So if we're going to pay for people to train, you need to hire them when we're done. And we're getting commitment from institutions to do that kind of hiring so that we know they have a job, which makes it much more worthwhile. We're also requiring the students to sign something that says that they're stay, and if they don't stay, they owe the money back or they can't stay in the country. It's called bonding. I hate that term because I don't like it, but it's sort of what the term that people have used. We'll develop something else. But with that idea in mind that we need to have then a solution there. Infrastructure, it's terrible. And how do you teach if you don't have the tools for teaching? So we actually built a partnership with GE, and we've put handheld ultrasounds into the hands of our volunteers so that they can see in real time at the bedside what's happening with patients. It's been an incredible teaching tool. We have worked to secure infrastructure gifts where equipment is being given to basically to sites, but what we've learned is that we have to actually then pay for shipping, and that's $30,000. So there's all this is to say that we're trying to engage in the problem as a whole by leveraging other partners to do some of the work that maybe we shouldn't do, but we also realize that we have to be advocates for the bigger voice. I'm going to take 2 more quick questions because I've already been told that we're out of time, so I promise we can talk after. We'll take 1 question and then take your question up. We'll do 3 more, sorry. We'll do it quickly. I'll answer quickly, yeah.
So it's that this exists, and I wanted to ask you about a couple other models and how much you guys, in terms of the mission creep idea of trying to expand your mission or reframe it or do it in other ways. A couple of friends of mine run Project Musa, which is in Mali, and they're using this system of community health workers, and they're like, oh, this is now the number 1 way to address child mortality. And then another one I read was barefoot doctors in India with this idea of training people on the ground. Again, similar ideas always, how can we expand, these 10 people train these 10 people, these 100 people, etc. How much do you all talk and exchange best practices and learn from one another and magnify your impact through that best practice sharing?
So I think all the time. I know Ari and I don't know the Barefoot Doctor folks as well, but there's a community of social entrepreneurs working in health that often end up in the same places. And so we spend a lot of time trying to talk and reaching out to each other, and we're always connecting one another because there is a lot to learn. And the whole point of this is to try not to be repetitive, but to be additive and to be complementary. And I think that one of the things that we do is we don't do community health workers because we rely on Muso or Last Mile Health or someone else to bring that piece in, but we bring in the skilled health professionals that provide the backup to them. And so that communication is critically important. Seed got designed the way it got designed because we looked at all the lessons learned for 20 years leading up to it. This was not a new idea, but it had stumbled along the way, and I think that that's been an incredibly important piece. So that's the quick answer, because I want to be able to just do a couple more. Yeah?
Yeah, I work with a group that's doing distributed renewables in Uganda and other places in sub-Saharan Africa. And we've been solar electrifying very rural off-grid medical clinics. And one thing that we found is that in electrifying the clinics as well as the dorms or the places where the nurses are staying has led to an incredible increase in our retention rate of the rural healthcare workers. And so my question is, do you have an energy perspective in your program?
We don't, but we need one, because if we're doing surgeons or anesthesia or things like that, the ability to have a reliable electrical source or some sort of electrical source is incredibly important. And energy usage and also conservation and environment is all critically linked to health and to health parameters. It's just an area we haven't fully developed out yet, but not because we don't want to. It's just because we're 3 years old and we're trying to, figure out all the pieces. So I would welcome a conversation. Thanks.
Hi, thank you for your presentation. With your plans to expand to other countries, are you also planning on increasing the number of nurses and doctors that you're sending?
So we are. The growth expansion over the next 5 years is so right now we're going to go to 5 countries in partnership with PEPFAR and the Peace Corps and stop there. In part because we want to be conscious of the recruitment sort of pool of doctors and nurses available with other programs and to be able to recruit really talented people to go. And we think we'll be able to, but the goal is to get to about, right now we're slated to put 60 in the field for next year, and then we're going to go up to ideally about 100. And we've budgeted to go up to 180 if we wanted to. We're scaling that back a little bit more, and we'll probably go to 100 with the idea that it would be a mix of health professions, doctors, nurses, midwives. We might throw in physical therapists or pharmacists or some other health, or NPs or PAs to fit in that mix, would be part of the expansion. And then Seed's ultimate expansion is to partner with the UK government or the Norwegians to be able to go to other countries. So to take our model and then leverage other partners to build our model out, or and to be adopted in other ways. So that's the hope. Yeah.
So I'm a nurse and I'm actually in the application process. Do you have any?
With us?
I am a nurse.
Yay!
So I've had my first interview and I'm waiting for an interview with Seed Global Health. Do you have any advice?
No. I think the advice is no. There's advice for applying. No. I think who you are, your interest in doing this, your willingness to commit a year, and to know that it's tough work but rewarding work is what this is about. And we're just very excited to have interest. And I think the only thing I will ask is a favor to tell all your friends and for everybody to Facebook and spread the word, because we don't exist without, all of you helping us. And so I will look forward to hearing about your application and happy to chat after. I know we're desperately out of time. I've been really bad about ignoring the red light. So thank you very much, and I will see you shortly.